Welcome back to this discussion on Health Digest, and today we are discussing one of the key pillars towards achieving universal health coverage, and that is access to health facilities. Now, before we get into this second part of our discussion, let's look at a clip of how residents access health services in Mageta Island, that is in Lake Victoria. Take a look. Mageta Island is another hard-to-reach area. Life has taught villagers here to make use of the natural resource that is the lake for everything. With a wooden boat, a patrol boat and water ambulance, residents here are right in their assessments that they have it better than their neighboring islands. Health services, far in between as they might be, they are somewhat accessible.
It takes almost 45 minutes. If you go with these ordinary boats. But with that speed boat, it can manage 10 minutes.
At times when it's raining, you find that this place is flooded. You have to take off your shoes to get to the ferry, and at times the water is dirty, it's muddy, and there's where you can get an infection.
Mercy Atieno, a resident of Mageta, knows too well the questions of accessibility in this area. During the birth of her second child, she had to be taken to the mainland for delivery.
Ukiwa na emergency unahudumiwa hapa kwanza, iwapo imewashinda ndio itawabidi upelekwe nje huko Bondo. Lakini hautaenda mwenyewe wala mtu ambaye umekuja naye, utaenda na daktari ambaye pia atakuwa nawe humo ndani mpaka ufike huko Bondo.
Now, that's the view of a resident from Mageta Island, how they access services at the island, and also healthcare provider, that is Bilha, who has to cross from the mainland to Mageta Island to provide these services. And I want us to go straight into the discussion about staffing. We know that the shortage of healthcare workers is one of the constraints towards achieving health and development goals. And we've heard that even accessing that area puts the healthcare workers at risk. And I want to start with you, Evelyn. How do healthcare workers, how do you make it easy for the health providers to actually provide services in these areas, given that sometimes the natural and the environmental factors, like accessing the island when it rains and it's flooded and they can't get there, or when they are in transit and the weather changes, puts their lives at risk? How do you make it easier and better for these healthcare providers to still continue providing those services?
Yes, thanks, Mercy Korir, for that. I know human resource for health has been a challenge for the national, from the national level to even where we implement. And also the kind of what we discussed earlier in terms of their safetiness, and in fact of issues of housing, issues of education and the rest is a challenge for them. Mm-hmm. So clearly, what we've managed to do as Omega Foundation with the health service providers is kind of motivation, because there's nothing much you can do, because motivation in terms of capacity building. Because for you to access health services, you need to get somebody who is able to provide the health services. The current programs you are running is family planning and park services in the facilities you are implementing.
What are park services? Just for the viewers to understand.
Post-abortion care services. Mm-hmm. Yeah. So in such a scenario, we are able to build the capacity of the service providers so they're competent enough and they're productive and responsive in service delivery. And in terms of motivation, they see us visiting that place, like the supervisors, inclusive of Ministry of Health supervisors. So we walk into those places and support them in terms of engagement, in terms of their service delivery. So in such scenarios, they see us like, sometimes we discuss with them their issues that they raise during these visits, that these issues end up reaching the county level, of which when they reach county level, there's a way the county is able to implement some of these, the concerns they've raised. So that's one of the aspects that maybe we have managed to motivate. Another thing that we were thinking as program people, that we are thinking to share with the county, is that we need to like do a relocating all staffs to these sites, so that there's no one permanently placed there that you posted at Mageta Island. Let everybody have a feel
so
of
that
how
they
to
rotate
so that
and
they
provide services and have a feel and experience of the different places.
Exactly, and this one will improve quality of services because everybody will feel. We would like to know what are some of the improvements that each and every person can be able to improve in such a scenario. And this can really improve quality of services rather than just dropping somebody there for 5 years and then this person will definitely ask for a transfer. Bring another new person who is under, who has no capacity to provide some of these services. So you need to restart again. Okay. So there should be a way of just rotating this staff to these areas. Yeah.
Aga, what would motivate you as a healthcare provider to live in those underdeveloped areas and continue providing services even when the transfers and the relocations are not happening? What motivates you individually? What would motivate a healthcare provider to stay in those areas and continue providing services? We saw the other day that the teachers in Wajir were not feeling safe staying there and they were actually moving away. What motivates you as a healthcare provider to continue staying in those regions and continue offering services?
Thank you, Mercy. One of the key motivators is your focus. What do you want to achieve? Your passion. When you have the passion to help, then you can even help under the water without oxygen. So it is the passion that drives me in providing services in the hard-to-reach area, in the rural areas. That is the key thing. Otherwise, the other things that will become as an auxiliary is accessibility to where I am going to, availability of equipment to use to serve, availability of drugs that I can give to my patients when they come. You will feel so bad when you clerk a patient, get a diagnosis, but you have no drug they can get back home. It is so demotivating. So when these other structural systems are in place, then you will feel very motivated.
Robert, with all those factors that demotivate, and I know how it feels like to know as a healthcare provider that you can help somebody, but your hands are tied because of the other systemic faults or the other systemic inadequacies. What then makes people continue, or healthcare workers continue staying despite all these other issues, apart from the, the self-drive that Aga is talking about? Are there any other issues that would incentivize these healthcare workers to continue staying in those areas or to continue visiting those areas and providing services?
Indeed, systematic issues and issues around policies and laws are also another factor that could potentially motivate these people who are working in the hard-to-reach areas. And particularly if you're talking about issues of human resource for health, if you're talking about issues of health systems, there is indeed a key component of health financing. You find that nationally, in 2001, Kenya committed to, alongside other African countries, to at least be allocating 15% to
their budget declaration.
Their budget declaration.
They should have 15% of the national budget towards healthcare.
Towards healthcare. But if you look at, if you add the combined, because now there is health is devolved, so if you combine the allocation by the counties and by the national government, you still find that it is less than 10%. So that means that some of the core functions that they are supposed to do, they end up not doing or are partner supported. So the first thing that needs to be done to ensure that first there is access in these hard to reach areas, and also that the people, the human resource are motivated, is the issue of human health financing. So first you invest in the facility themselves, so that when you have all the equipment that you need, you have all the commodities that you need, because as Aga said, it is indeed very demotivating for somebody to work in such a hard area and look at your patient and know that there is nothing that you can do for them. Yet, the service that they come for is something that could actually really be done easily. So one thing that needs to happen is the need for increased budgetary allocation to health, to at least the proportion that the government has committed to, and in the context of the county government, since health is indeed a key function of the county government, there is need for them to show priority to the health sector, show priority to the healthcare worker. And that again is related to the issues of the industrial actions that we have been seeing of late.
Witnessing
So,
in the health sector.
Yeah, so you find a situation whereby the hard to reach areas are actually the areas that suffer the most in these cases of industrial disputes and strikes and all of this. So in order to be able to motivate these workers, there's need to also look at the issues of welfare, issues of training opportunities, issues of other benefits that should come to them, because ideally they are working in very hard to reach areas.
Okay. And I want us from that cue to discuss devolution of healthcare. We know health was one of the major devolved function to the health, to the counties. And the idea, I would think, behind devolving health was so that the counties can have unique and innovative ways to solve the health issues or to provide better health that suits their context. Is this happening, Aga? Are we seeing, are people in those marginalized, hard-to-reach areas seeing the benefits of devolution, with this grand idea that they should have innovative ways that they get solutions that suit the context in which they are at?
Sure, I think I will talk about one of the innovations that the county governments can use to spur the health. However, we have seen a mixed kind of a reaction. You look at different counties, we talk of Makueni, we are seeing them almost achieving the universal health care. But then again, you go to other counties that the things are still very difficult. From the southern Nyanza region or the southwest region part, when we look at it, there has been more investment into facilities, less into equipment, a little bit of investment on providers. The number has actually increased as compared to when we were at the national government. So I will congratulate the county governments for doing that. However, in my understanding of devolution, I will borrow from Australia. And the system of devolution that probably will work, if I take an example of, give an example with Kisumu, is to get the county referral hospital, have doctors, but then attach doctors to the peripheral facilities, that is the health centers and the dispensaries, so that we move the backlog at the county referral hospital and the Jaramogi referral hospital back into the village.
The lower level facilities.
So that if we can do a surgery at the Kisumu County Referral Hospital, somebody in a Ahero sub-county hospital, you can get back into the ward and still be given the same standard of treatment that you will have received at the Jaramogi Oginga Odinga Referral and Teaching Referral Hospitals. So what we are failing to do, we are talking of devolution, but we have not devolved. We want to fail. I want to see a cesarean section being done in a dispensary right in Nyakach at the dispensary there. And then the management continues. Otherwise, that is why when you go to the county referral hospital or to Jaramogi, you will find patients lying maybe on the ground because of overcongestion, because we lack equipment and manpower, the required manpower in the lower level facility. So when we do that, we will move. But before we do that, it will still be very difficult.
Evelyn, are the effects and the impact of devolving healthcare being felt either positively or negatively at the grassroots levels?
Just to add in to what my colleague Aga said, devolution, yes, it's there. And what we are currently seeing are structures which are coming up in terms of facilities. And facilities cannot run alone without the human resource for health, and also issues of equipment. Facilities are good, but the planners should think of what next after building the facilities. We need to have the health workers. We need also to have the equipment on board, and so that they can be able to support the local mwananchi, the community person. But currently, devolution is there. And our worry in terms of devolution is also on their budgeting in terms of health. You get, health has several programs within health. Yes. But you get the budget under health is blanket, in that if SARA has 5 billion on health, health is 5 billion. So what is under immunization? What is under family planning? What is under maternal child health? It's nowhere. So there's no accountability. At the end of the day, when there's no accountability, that is why now we have cases of facilities cannot perform. Because no one can be asked that if you budget for maternal child health 20 million, what did we see on maternal health? What did this money spent on? Yeah? There's nothing like that under Siaya County. But you find other counties have gone ahead like Vihiga. I think it's Vihiga or Kakamega, where there's program-based budget. So when there's program-based budget, somebody is accountable. If I was to buy commodities and equipments worth 50 billion, then somebody will come to you and ask, were these things done? This is lacking in some of these countries. That needs to be strengthened so that devolution can really work in terms of health.
Okay. I'll come to you, Aseda, on the same issue of devolving health, but after we look at this final clip on Remba Island specifically, and what the 10,000 residents within Remba Island have to say about their access to healthcare. Let's take a look at that. Remba Island gives one an inviting feeling that is both homely and warm. Forget the rough tides. Women washing utensils by the shore, men pulling together to reel in boats, fishermen preparing their fisher nets. The 10,000 residents here going about their daily activities.
Kwa sasa hivi means of emergency, ukipata mgonjwa amegonjeka kwa ghafla, kumpeleka kwa hata akipewa referral ni ngumu juu hatuna ile fiber boat.
It is hard to imagine how an emergency here can be safely and quickly attended to. People here have learned how to work ahead of their emergencies.
The firstborn, I was away from this place. The secondborn, I had complications.
Well, that's the views of residents from Remba Island, a mother who had to plan beforehand and organize how she would deliver at the mainland as opposed to the island where they have only one facility and 2 nurses and nothing else much. And in case of an emergency, then they are caught between a hard and a rock, a hard place. They are caught between a rock and a hard place. Now, Robert, we were discussing about devolution, and we've seen what is happening at Remba Island, where people actually have to change their day-to-day living in order to go and, you know, access health facilities there. Is there anything that devolution or the devolved health function can do in order to improve such living situation and living standards for these people?
I think the first thing that we need to think about is the very idea of devolution itself. What is devolution? And it's very difficult to separate devolution and public participation, because public participation is indeed a critical component of devolution. This is whereby we are saying that people in themselves have the ideas that they need to be able to make the changes that they need in their community. So I think one of the things that need to happen for devolution to work perfectly is the need for strengthening public participation so that the people are able to choose their priorities. What do we want? The best. It's sometimes thought that we are talking about huge amounts of money here, we are talking about complex development issues, and therefore these people cannot be able to, provide any meaningful input on the same. But if you look at daily, if somebody has 100 shillings, for example, they will say that I'm using 10 shillings for food, I am using 50 shillings for accommodation, I'm using 10 shillings for whatever it is that they want. Therefore, from the very basic level, people are able to prioritize those things that are important to them. And for devolution to work, there is need for public participation. If you look at the Public Finance Management Act, the County Government Act, and even the Constitution itself, they provide for public participation. However, sometimes public participation is done for the sake of public participation. So there is no meaningful desire to see what the people actually need. That is why you hear the example of what Aga was saying, that you have a facility, which is a very nice facility. It is completed, but then people are not going to that facility, either because there are no drugs, for example, or there are no doctors, for example, or perhaps they needed the dispensary, yes, but perhaps they needed the road first to get to that dispensary. So I think for devolution to really do the work it's supposed to do, we need to reinvest in the people themselves and let the people generate the ideas that they want, what the development that they want. And this concept of development as a building, development as a facility is also some concept that we need to change.
We need to move away from
yeah, because
that.
Sometimes as a member of county assembly or as a governor, you are under pressure to say that I did that hospital, I did that. Yeah, but sometimes it's even more than just saying that I did that hospital. It is saying that I equipped that facility that was already existing, and now you can be able to access the services that you need.
Okay, thank you. Now I'd like to just now pick your closing comments on this issue. It's a major, from your discussion, it's a major issue towards actually achieving universal health care and universal health coverage in the country. I'll start with you, Aga, your closing comments.
I think I want to thank you for the show, and I want to encourage that we reach more to the community, allow them to participate, and let us empower them so that they can achieve their health goals, they can achieve their goals in life. But if we don't involve them, if we don't allow them to participate, then we may not be able to achieve universal health care in boardrooms.
Thank you. Evelyn, your closing comments.
Yeah, thanks for this show. It was a very important one. But what I would say in terms of achieving our universal health coverage, we are somewhere, we're on track. But what we really need to do is to redesign it so that the people's issues are catered. Let us understand, how do they feel? What do they say? What do they do in terms of their health matters? So all these issues that come from the people can be used to redesign whatever healthcare project you want to bring on board. And let's bring all the stakeholders, which some of them are the community. Let them come with their own issues. Let us not push issues to them, like what happens with our members of parliament and also the MCAs, who just feel that now this facility needs a tank. Did they tell you they need a tank? Maybe there's something else that the community
involvement is
so community
key.
Involvement is key in terms of us accessing universal health coverage.
Okay, thank you. Aseda.
The first thing that we need to look at when we are looking at issues of the unreached population is to try to find out who these people are and why we say they are hard to reach. We need to address the socio-cultural issues, for example, that make people and communities not want to or not able to seek services. We need to look at individual needs. Do I feel comfortable going to that facility? Why don't I feel comfortable going to that facility? And most importantly, we also need to look at the structural issues, the systematic issues, issues around policies, issues around resource allocation, so that we are able to ensure that indeed there is friendly services. The other thing is also investment. If you look at Kenya, for example, currently we only have 10% facilities that are providing youth-friendly services. So there is need for investment in the health sector so that we are able to reach not just the young people, but also other people who are also hard to reach as well.
Okay, thank you. Thank you very much for this discussion. We have been discussing a key pillar towards achieving universal health coverage, and that is access to health services and to health facilities. And with me in studio was Robert Aseda, who's a policy officer at NAYA, which is the Network for Adolescents and Youth of Africa. We've had Evelyn Ajuang, who's a public health nurse at Omega Foundation, and also Aga Mitoko, who's a clinical officer at Matibabu Foundation Kenya. That's all that we had for you this evening. On behalf of myself and everyone that has made this show possible, I want to wish you a very good night and enjoy the rest of your viewing. I'm Dr. Mercy Korir. Join us again next weekend as we have another discussion on Health Digest. Good night.